My next pleasure is to introduce our next guest speaker. That's Kristen Young. Kristen, that's over to you.
Oh, thanks, Anne-Marie. This is Kristen. I have stage 3C ovarian cancer, which is now recurrent, and I'm speaking today because I'm on an olaparib trial, and we'll talk about my experience. And initially I'll just talk about my experience of having ovarian cancer and the treatment, and I'll talk about what I think and what I feel about being on olaparib and on a PARP inhibitor and what that means to me and how that affects my life. So I was diagnosed in 2009. My pathway to diagnosis was a bit unusual, but I guess everyone's is a bit unusual because the symptoms are so vague. But I started with unusually large lymph nodes in my groin, but I didn't have some of the other symptoms of bloating and those sort of things. So I ended up having a biopsy of those lymph nodes, and they, to everyone's surprise, found a tumour that was clearly gynecological. But the funny thing about that is that I'd actually had the ultrasound that's recommended for ovarian cancer, and they didn't find anything. So I think my tumour was hiding. So I guess the takeaway lesson from that is that it can be a really unpredictable and variable pathway to getting your diagnosis. But for all that it was an unusual pathway, I had a very standard form of ovarian cancer. So I had the standard initial surgery and initial chemotherapy. It was the 18 weeks, and that just went along in like a pretty predictable way. It was difficult, but nothing unusual happened. And this is a picture of me after surgery. So I'd like to put that in so I can remember that it's not like that anymore, and you can just forget those bad times, but also to remember what it takes to go through this thing as well. So that's during my first chemotherapy, just after I'd had my head shaved, and then all those last stubbly bits then eventually fell out. You can see I'm quite pink-cheeked from my dexamethasone I've actually had a memory blank of what the drug is that you take to prevent the allergic reactions. But anyway, that's how I looked for about 6 months. But when I finally, finished chemo, I was thinking, the whole what now that we all think about, what's going to happen to me. And I'd read about things a bit, and my oncologist at the time referred me to a clinical trial. And I liked the idea of that a lot because I thought I may get some medical benefit from it. But for me, the thing that mattered to me most is I was going to get plenty of attention. So I was going to get doctors paying attention to me, checking how I was going. And I wasn't going to sort of suddenly be lost in the wilderness and wonder, what's going to happen to me. So I thought going on a clinical trial would sort of let me down easy. And if I benefited from it medically, then that would be great too. So it was really good. I was on a angiogenesis inhibitor, and which is Dr. Lederman said is to prevent the growth of blood vessels in tumours. Though I could have been on the placebo, and to this day I don't know whether I was on the placebo or not, but it didn't matter. That wasn't the main reason I was on the trial. But it helped me to gradually get back to normal life, and I knew enough about the statistics to know that a significant proportion of people in my situation were going to have a relapse, but years went on and on and on, and I still didn't relapse. So I began gradually to, get back to really a pretty normal life. It never completely goes out of your mind, of course, as anyone with ovarian cancer would well know. This picture is me doing some advocacy for Ovarian Cancer Australia at an afternoon teal at a ladies' golf day. But the way I sort of coped with it was by making sure I had plenty of information and treating it almost like a job for myself. So making sure I surrounded myself with a good team, the team being not only friends and family, but people who could look after my health, like obviously good doctors, but things like being a massage therapist, a physiotherapist, someone to help me with the risk of lymphedema, psychology, support groups, physical exercise, and all of those sort of things. But it was always the possibility of the relapse from around the corner. Now, when I was on the first clinical trial, I was not eligible for a PARP trial because at that time there were no PARP inhibitor clinical trials going on for women who hadn't had a recurrence. So ironically, I was thinking, you know, if I'd already had a recurrence, I would be able to get this wonderful PARP inhibitor drug, but I haven't. I have to wait my first relapse before I get access to this great new drug on a trial. But after 4.5 years of remission, then I had a relapse, which was wasn't very obvious at first. It took a while to diagnose because a lot of it was in my lymph nodes. A lot of those lymph nodes were very high up high in my abdomen, up under my diaphragm, and certainly you couldn't feel them from the outside. And they also didn't cause a very big increase in my CA125. But the very first thing I talked to my oncologist about is, when we finished treatment for this relapse, going on a PARP inhibitor trial. So my day had come. So back into more surgery, and this time it was a difficult surgery, just mainly because I had some side effects from the surgery that I hadn't expected. A leak of lymphatic fluid into my abdomen that was swelled it all up for about 2 or 3 months. But once I settled down from that, I started a second round of chemo. Now this is where it got interesting, because I knew at that time that the PARP inhibitor trial that I wanted to go on had a closing date, about 3 or 4 months down the track. But it required that I had done 4 cycles of chemotherapy to make me eligible to go on the trial. Initially, I was too sick to start the chemo, so I was negotiating with my doctor to try and get started on my chemo so I could count out the number of chemo sessions I had to get done to meet the criteria for the trial so I could get on the PARP inhibitor. So there was this race against time to complete the minimum requirements. And the funny part about that is, towards the end of the chemo, as I was going through the suitability to get on the PARP inhibitor trial, is they had a minimum hemoglobin level I had to get, and because I'd been really unwell after the surgery, the hemoglobin was low. So I started thinking up desperate ways to meet the minimum cutoff for the hemoglobin. So I come in for my test. I don't know if I should say this, but I come in for my test, and I'd make sure I really dehydrated before I went in, because I'd heard from a doctor friend that would make your hemoglobin level higher. I was eating large, rare steaks for a couple of days before, hoping, probably not correctly, that would increase my hemoglobin. But anyway, I finally got on to the trial, and then I thought how lucky I was, because this is what I'd wanted really from the beginning. So, and I think it's because, as someone with BRCA, it was something that enabled me to have a greater opportunity than what was available to me if I didn't, and that was just to wait, and to wait basically for my next relapse and not to do very much. So, life on the PARP inhibitor. It is a placebo trial, but I believe, and my doctors believe, that I'm actually on the active drug, and we believe that because of my side effect profile. And as Dr. Lederman was saying, one of the main side effects for me is fatigue. The difficulty is knowing, how much of the fatigue is due to the olaparib and how much of it is to do with, being postmenopausal now, or to do with just general post-cancer fatigue and ageing. A couple of times now we've worked out that I have a 2-week drug holiday to see whether it makes any difference. or I think an interruption is what Dr. Lederman was calling it. And I know that it certainly does, if I'm off it for 2 weeks, I do feel like I have more energy. So I do attribute a chunk of the fatigue to the effect of the drug. So there are a few other minor side effects that are less troubling than the fatigue, and that includes mild nausea. This just a photo of me recently wearing my teal for an ovarian cancer function that I was on my way to. So mild nausea, which I only ever needed to manage with, basically taking Stematol, and doesn't affect me very much at all, but it's definitely there. The other one is a suppression of appetite, like losing interest in food, which I consider to be a good thing in some ways, because it helps me to eat more healthily and manage my weight, and so I'm trying to capitalise on that a bit. But a few other minor things like mouth sores, and I also get really funny dreams, which a few people on PARP inhibitors apparently report as well. So, but it has led for me to make lifestyle changes. I've now formally gone down to working part-time. And this is a photo of us recently, just a couple of weeks ago, at the Ovarian Cancer Australia 15th birthday celebrations at New South Wales Government House, and that's us with the Governor of New South Wales. So, and this leads into the fact that I think one of the things that I can do with my cancer experience is to try and send a bit of a message to other people about living with cancer in a way that gives you a degree of still having a reasonable quality of life. And one of the things I've also done is to assist Ovarian Cancer Australia with some of the advocacy to trying to get olaparib put on the Pharmaceutical Benefits Scheme, or the PBS, so that it's a subsidised drug for everybody to use, all those that are eligible for it. So living every day on a clinical trial on olaparib. This is a photo of my last holiday when I was walking in Switzerland. And that was actually the day after, the first day of my drug holiday. I was actually really sick that day because I believed I was withdrawing from the drug. But when I got to the top of the hill, I had a beautiful view, so I felt better. But anyway, twice a day I take my two tablets, and I set my alarm. So my daily routine is driven by 7:30 a.m. I have to be up for my drugs, and 7:30 p.m. and you have to take them with food, so I've got to organise all my meals around that. But that's a whole question, is this worth it? I believe, and I think the evidence is developing, that this does make a difference to your survival. And this is living with the side effects of it, and living with some restrictions on my life that come with that. I think I'm calculating that is worth that for me. Because then I think, what would have happened? How would it have been if I hadn't got onto the trial? So this is a picture of my dad. We got the BRCA gene mutation came down through my dad's line, and he passed away from prostate cancer in 2003. So one of the things is if olaparib doesn't extend your overall life, it does, I feel, improve your quality of life. So even if it isn't a cure, what seems to be important for me and for other people is that living your life now, when you're working, travelling, and fulfilling your responsibilities, it seems to be able to increase that quality of life. But what about the people, this is my family, and this is one of the last sort of things that Dad did. He paid for my 40th birthday party not long before he died. But is it, I feel like I'm lucky, and because I'm BRCA and because of circumstances that I have access to olaparib, but there are a lot of people who don't have access, either because they're not BRCA or they're unable to get onto the compassionate access program, or they missed out on a trial. And sometimes I feel a little bit, a little bit guilty that I've had that access and other people haven't. At the same time, though, I know that people feel there's a sense of hope to see that even if there's a new treatment that doesn't benefit them, that they're glad to see that there are new ideas out there and that the medical profession is working to find solutions that may eventually benefit even more people. So there is a sense in which, even though a relatively small number of people benefit from this drug at the moment, it does represent a new way of thinking and a sense of hope for people going on into the future, because it is a really different way of thinking about of treatment. So just my final words is that you've got to work out, living on olaparib long term is where you fit. I'm not someone who's on chemo. I'm not really someone who's in remission. I'm not cured. I'm this person that's on this long-term, low-level treatment. I look completely normal. I've got all my hair. I don't look unwell, but I know this, I'm still living with the effects of it and living every day with being unsure whether this drug, how long this drug will extend my life for. So in the end, I'd just like to say that I'm delighted to see that there are new ideas out there and that there is some hope. And as individuals, that there's a lot of the science here, but it's really helpful to try and understand as much as possible so that when you read and things and then go and talk to your doctors, that you know what the risks and benefits are of options as they get presented to you, and keep your eyes open for new things as they come out. So if and when I relapse again, I'll be looking for new trials. And thanks to Ovarian Cancer Australia for supporting all of us, giving us opportunities to support each other too. And that's all from me.
Thanks so very much, Kristen. You know that I'm one of your biggest fans. I really enjoy listening to you. I appreciate you coming in and doing this webcast this evening. I'm wondering if we have any questions from our participants, and if so, please type a message in and we can respond to it. I can see that there's another question that's been put up that I imagine I'm going to offer this to Jonathan. Question comes from Vesna. Are there other avenues being explored for ovarian cancer treatment, like systemic RNA delivery? I can't even finish.
Yeah, no, I can see the question. So this is really a question about immune therapy, which is a very exciting area, a new area in cancer treatment, and it's been shown to be really have quite dramatic results in melanoma and in some lung cancers, and now this work is extending into ovarian cancer. But it's at very early stages at the moment. There are clinical trials, and there is a clinical trial, there's been more than one, and there's another one opening, I think, in Australia very soon, looking at these immunotherapy treatments. The types of immunotherapy that are being looked at the moment are with drugs that are actually generally fairly well tolerated. They have to be given by injection, but they're fairly well tolerated, and they are not particularly complex. The question you are posing is a complex scientific question about immunotherapy, and it looks like you've heard about this perhaps from a study in Germany from looking at the question. Those sorts of trials are being thought about around the world, but so far that approach hasn't really been leading very far. But I think where we are hoping that we will see progress in the next 3 or 4 years is with these immune checkpoint inhibitors in ovarian cancer, in the same way that we've seen it in melanoma and lung cancer.
Thank you very much, Jonathan. In light of lack of questions, is there anything, Kristen or Jonathan, that you would like to finish off with?
Well, I would just like to say thank you, actually, Anne-Marie, again, for inviting me onto this, and to Kristen for really giving such a wonderful talk about your life, coping with the disease with such feeling and such clarity. It was a very moving talk, and I appreciated listening to you. Thank you.
Kristen, is there anything you'd like to say before we sign off?
Just think that if I sort of I can't think what I was going to say. I think I was just going to say that if in trying to work out, because my head had adjusted to, looking only ahead a fairly short time, but now due to olaparib, it's possible I'm going to live for quite a lot longer. And I don't know, no one knows anything like that. But if I am going to live a long time, I sometimes think, do I want to live like this, with this, reduction in my work capacity and the reduction in my hobbies and interests? Then I think, if I were to go off olaparib, then the question would be moot, because then I wouldn't be living a long time to even worry about that. So it's, I think, a question for all of us who are living with a recurrent ovarian cancer is what do we want to do with the time, and how do we want to get the best value out of the immediate time and not to think too much into the future. And olaparib's made that time a lot more rubbery. And that's quite interesting. It's quite challenging. So that's all I've got to add there.
Thank you very much, Kristen. Now, look, we've got a couple more questions that's just popped up, which I'm excited about because we do have 3 minutes left. I'm going to pose these questions. Jeanette asks, what do you take for mouth sores?
So I'm not sure whether that relates to chemotherapy or olaparib. It's not particularly common with olaparib, but it can occur. So I think it's difficult to know how to answer that depending on what it relates to. But there are a number of medicines, I'm not sure whether the names are the same in Australia as they are in England, for dealing with the symptoms, such as Diflan mouthwashes and Corsido, which is a sort of disinfecting mouthwash. And then if it is associated with olaparib, then this would be a time to rest, a drug holiday, if you like, for a couple of weeks to allow the mouth to heal. And again, restarting, it may not occur again. But if it does, then that would be an indication to reduce the dose. If it's to do with chemotherapy, then if it's really significant and troublesome, then you might need to have a reduction in the dose of one of the drugs that you're taking.
Thank you. Another question comes from Denise. Hi, Denise. Can you go back onto chemo after being on olaparib if cancer grows or recurs?
Well, that's a very good and important question, and the answer is yes, you can. We know from the studies that we've done that many patients who go back onto chemotherapy will again have a benefit from chemotherapy. But we looked at that question a little bit earlier in a slightly different way as to how long that chemotherapy effect might last and whether olaparib might reduce that effect of the chemotherapy, and we don't really know the answer to that. But there are certainly many women who have been on olaparib for a while. The drug then, for reasons that we don't understand, doesn't work anymore, and they then go back into chemotherapy, and they have a good response to chemotherapy, and sometimes several other lines of chemotherapy that follow after that. So the answer to your question is yes.
Thank you. And there's a comment from Gail. Hi, Gail. Who says, fantastic presentation, and that's a beautiful segue to say that we're about to wrap up our webinar. That I'd like to thank Jonathan and Kristen. Heartfelt thanks. Very brilliant, useful information, and we appreciate the investment in time and being here and giving us that information. This webinar webcast will be recorded and is being recorded, has been recorded, and will be made available on the Ovarian Cancer Australia website shortly. Thank you everybody for attending tonight's webcast. I would encourage you to stay online for just a little minute longer and answer some questions. We have a survey. That survey we use to inform our programs and services. That your feedback tells us what content to deliver in different vehicles. So thank you everybody for attending today's webinar, and we'll see you at the next one.